Welcome back to Surgeon Smart Cut to the Core podcast, where we break down essential surgical topics. I'm your host, Major Munish Chauhan, and I am a General Surgery Registrar in the British Army. I'm also a Senior Research Fellow at the Center for Army Leadership. Feel free to connect with me on LinkedIn. Today we're diving deep into Barrett's esophagus. We're going beyond the basics. Think deep anatomy, physiology, even getting down to the molecular level. This one's for the doctor, so buckle up for a detailed exploration of this fascinating condition. Okay, let's unpack this. What exactly is Barrett's esophagus? It's more than just a bit of heartburn, right? We're talking about a premalignant condition where the normal squamous lining of the esophagus, that tough protective layer, actually transforms into columnar epithelium. And that's important because columnar epithelium is more like what you'd find in the intestine.
Here's where it gets really interesting. The appearance of these intestinal-like cells in the esophagus is a red flag. It significantly increases the risk of developing esophageal adenocarcinoma, a serious type of cancer. And one of the key characteristics of Barrett's is the presence of these goblet cells. You don't normally find them in the esophagus. They're responsible for producing mucus, and under the endoscope, they give the affected area that distinct salmon pink appearance. Now, we know there's a strong link between Barrett's and GERD, that chronic acid reflux that so many people experience. It's like a constant irritation, like a sunburn that never fully heals. This ongoing assault on the esophageal lining seems to be the main culprit behind the cellular changes that lead to Barrett's. But here's the thing, not everyone with GERD develops Barrett's. So the question is, what tips the scales? What makes some individuals more susceptible? Well, it seems there's a combination of factors at play. Some are non-modifiable things you can't change, like being male of white race or over the age of 50. And of course, family history plays a role. If you have a family history of Barrett's or esophageal adenocarcinoma, your risk goes up. Then there are the modifiable factors, things you can potentially control, like central obesity and smoking. Whether you're a current smoker or have a history of smoking, these lifestyle factors seem to contribute to the development of Barrett's. Now, for those of us in surgery, understanding these risk factors is absolutely crucial. It helps us identify patients who might benefit from closer monitoring or even early intervention. So we've talked about the what of Barrett's esophagus. Now let's delve into the how. How does this transformation from squamous to columnar epithelium actually happen at the cellular level? Well, the process is complex but fascinating. It involves a cascade of molecular changes triggered by that constant exposure to acid. Think inflammation-altered cell signaling pathways, basically a whole chain reaction at the cellular level. One of the key players in this cellular drama is a protein called CDX2. It's normally found in the intestines, where it helps regulate the development of intestinal-type cells. But in the setting of chronic acid reflux, CDX2 can get activated in the esophagus. And that's where things get interesting. Because CDX2 acts like a master switch, flipping the script on the esophageal cells. It essentially reprograms them, causing them to differentiate into those intestinal-like cells that characterize Barrett's. It's as if the esophagus is trying to mimic the intestine, hoping to better withstand the acidic onslaught. But as we know, this adaptation comes at a price, an increased risk of cancer. And then there's the role of bile acids. These compounds, which are normally involved in fat digestion, can actually exacerbate the damage caused by acid reflux. They disrupt the normal protective mechanisms of the esophageal lining, contributing to inflammation and those cellular changes we've been talking about. And of course, we can't forget about genetics. While GRD is the environmental trigger, our genes also play a role in determining our susceptibility to developing Barrett's. Some individuals might be genetically predisposed to this condition, making them more vulnerable to the effects of chronic acid exposure. Now, one of the biggest mysteries in Barrett's research is the origin of those metaplastic cells. Where do they come from? Do they arise from the existing squamous cells transforming their identity under duress? Or do they have a different origin altogether? There are a few theories out there. One intriguing possibility is that they come from bone marrow-derived stem cells. These cells have the remarkable ability to differentiate into various cell types, and some research suggests that they might migrate to the esophagus and contribute to the development of Barrett's. Another theory involves the presence of embryonic stem cell remnants at the squamocolumnar junction, that area where the squamous lining of the esophagus meets the columnar lining of the stomach. These dormant cells, perhaps awakened by the chronic inflammation of GERD, might differentiate into those intestinal-like cells, fueling the development of Barrett's. It's like a cellular whodunit, and the investigation is ongoing. But unraveling the origin of these cells could have significant implications for how we understand and treat Barrett's esophagus. Now let's shift our focus to what we see under the microscope, the histological features of Barrett's esophagus. The defining feature, of course, is that intestinal metaplasia, the replacement of the normal squamous lining with those columnar cells resembling the intestine. And within this metaplastic epithelium, we often see those goblet cells we mentioned earlier, those mucus-producing cells that are typically found in the intestines. Their presence is a key diagnostic marker for Barrett's. But it's not just about the presence of intestinal metaplasia. It's also about the degree of dysplasia, those precancerous changes within the cells. Dysplasia is graded on a scale from indefinite to low grade to high grade. High-grade dysplasia is the most worrisome, carrying the highest risk of progressing to cancer. The pathologist carefully examines the biopsy, looking for specific cellular features that indicate dysplasia, such as changes in the size and shape of the cells and their nuclei. This histological assessment is crucial because it helps guide our treatment decisions. The presence and grade of dysplasia determine how often we need to do surveillance endoscopies and whether we need to consider more aggressive interventions.
Speaking of endoscopy, it's the gold standard for diagnosing Barrett's esophagus, specifically esophagogastroduodenoscopy, or EGD. This procedure allows us to directly visualize the lining of the esophagus, see those characteristic changes, and obtain biopsies for that all-important histological assessment. During an EGD, we're looking for that telltale salmon pink color, indicating intestinal metaplasia. We pay close attention to the squamocolumnar junction, where the two types of lining meet. And we follow a standardized protocol for taking biopsies to ensure we get a good sample for the pathologist. But endoscopy isn't just about diagnosis. It's also a crucial tool for surveillance monitoring patients over time to see if there are any signs of progression or recurrence. How often we do these surveillance endoscopies depends on the initial dysplasia grade. Patients with no dysplasia might only need them every few years, while those with high-grade dysplasia might need them much more frequently. And endoscopy also plays a vital role in intervention. It allows us to perform endoscopic eradication therapy, which aims to remove or destroy the Barrett's tissue and reduce the risk of cancer development.
So endoscopy really is at the heart of how we manage Barrett's esophagus, from the initial diagnosis to long-term monitoring and treatment. And when it comes to treating Barrett's esophagus, one of the first things we focus on is controlling that underlying GRD. Remember, chronic acid reflux is the driving force behind this condition. So proton pump inhibitors, or PPIs, become our trusty allies. These medications effectively reduce acid production in the stomach, minimizing the damage to the esophageal lining. And it's not just about symptom relief. PPIs might actually help slow down the progression of Barrett's by reducing that constant inflammation. Lifestyle modifications can also play a role. Things like losing weight, avoiding large meals, and eliminating trigger foods like caffeine and alcohol can all help minimize acid reflux. But what if GRD control alone isn't enough? That's where endoscopic eradication therapy, or ET, comes in. ET encompasses a variety of techniques that aim to remove or destroy the Barrett's tissue, reducing the risk of cancer. Radiofrequency ablation is one such technique. It uses heat generated by radio waves to essentially burn off the Barrett's lining. Cryotherapy, on the other hand, involves freezing the tissue using liquid nitrogen. And then there are techniques like endoscopic mucosal resection, where we actually surgically remove the affected segment of the esophagus using specialized instruments. The choice of ET technique depends on a number of factors, including the size and location of the Barrett's segment, the presence and grade of dysplasia, and the patient's overall health. But the good news is that ET has proven to be highly effective in eradicating Barrett's tissue and reducing the risk of cancer development. Now, in some cases, surgery might be recommended. This is typically reserved for patients with high-grade dysplasia or early-stage cancer that hasn't spread beyond the esophagus. The most common surgical procedure is esophagectomy, where we remove the esophagus. It's a major surgery, of course, but it can be life-saving in certain situations. The decision to undergo surgery is always made on a case-by-case basis, carefully weighing the risks and benefits and considering the individual patient's circumstances.
So we've got a range of options for managing Barrett's esophagus, from conservative management with GRD control to more invasive interventions like ET and surgery. And the key is to tailor the approach to each individual patient, ensuring the best possible outcome. But remember, even after successful treatment, Barrett's esophagus can come back. That's why surveillance is so crucial. It's like our safety net, allowing us to catch any recurrences early on when they're easier to treat. Surveillance typically involves those periodic endoscopies we talked about earlier, where we can carefully examine the lining of the esophagus and take biopsies if we see anything suspicious. How often we do these endoscopies depends on that initial dysplasia grade. Patients with no dysplasia might only need them every few years, while those with higher grades of dysplasia might need them much more frequently. Surveillance is all about being proactive. It's about staying one step ahead of the game and minimizing the risk of complications down the line. And as we continue to learn more about Barrett's esophagus, we're seeing some really exciting advances in how we diagnose and manage this condition. One of the most promising areas is artificial intelligence, or AI. Researchers are developing AI systems that can analyze endoscopic images and help us detect dysplasia more accurately and efficiently. Imagine having an AI system that can spot subtle changes in the esophageal lining that might be missed by the human eye. That could be a game changer for early detection and intervention. We're also seeing advances in non-invasive diagnostic tools. For example, there are swallowable capsules that can capture images of the esophageal lining as they pass through. These capsules could potentially eliminate the need for traditional endoscopy in some cases, making diagnosis easier and more comfortable for patients. And then there's the search for biomarkers, specific molecules in the blood or other bodily fluids that can signal the presence of Barrett's esophagus or predict the risk of progression to cancer. A simple blood test that could identify high-risk individuals would be a major breakthrough. So the future of Barrett's esophagus management is looking brighter. We're on the cusp of some really exciting developments that could revolutionize how we approach this condition. Now let's talk about personalized medicine. This is the idea of tailoring treatment to each individual patient, taking into account their unique genetic makeup, lifestyle factors, and disease characteristics. In the context of Barrett's esophagus, personalized medicine could involve identifying genetic markers that predict an individual's risk of developing the condition or progressing to cancer. We could then tailor surveillance schedules based on that risk profile, ensuring that patients who are at higher risk get monitored more frequently. And we could use biomarkers to select the most appropriate treatment options for each patient, sparing those who are unlikely to progress from undergoing unnecessary procedures. Personalized medicine holds immense promise for improving the way we manage Barrett's esophagus, delivering care that is truly tailored to each individual.
But we have to acknowledge that a diagnosis of Barrett's esophagus can be a lot for patients to process. It's a precancerous condition, and that can be scary. It often requires ongoing monitoring and potentially invasive procedures, and that can be stressful. So as surgeons, we need to approach these patients with empathy and understanding. We need to provide clear and comprehensive information about the condition, its risks, and the available treatment options. And we need to make sure they feel supported and empowered throughout their journey. We also have to be honest about the limitations we face in managing Barrett's esophagus. We've made incredible strides in recent years, but there are still gaps in our knowledge. We don't fully understand why some people with GRD develop Barrett's while others don't. We can't predict with certainty who will progress to cancer and who won't, and we don't yet have a cure. These limitations underscore the importance of ongoing research. We need to keep pushing the boundaries of knowledge, searching for answers, and developing better ways to prevent, diagnose, and treat this condition.
And that brings me to the importance of the multidisciplinary team. Managing Barrett's esophagus is rarely a solo endeavor. It requires a collaborative approach, bringing together experts from different fields. We need gastroenterologists to perform endoscopies and biopsies. We need pathologists to analyze those biopsies and give us that crucial information about dysplasia. And we need surgeons to step in when surgical intervention is necessary. We also need nurses, dietitians, psychologists, a whole team of professionals working together to provide comprehensive care for our patients. And at the center of it all is the patient. We need to remember that they are the ones living with this condition, and their voice needs to be heard. We need to make sure they understand their diagnosis, their treatment options, and the potential risks and benefits of each approach. And we need to respect their decisions, even if they choose a different path than we might recommend. This collaborative approach, where we work together with our patients as partners, is essential for ensuring the best possible outcomes. It's about more than just treating the condition. It's about treating the whole person. Now let's shift gears and talk about the role of genetics in Barrett's esophagus. We know that GRD is the primary trigger, but genetics also plays a significant role in determining an individual's susceptibility to developing the condition. Researchers have identified certain genes that might increase the risk of Barrett's esophagus, but the exact mechanisms are still being investigated. Some of these genes are involved in cell growth and proliferation, while others are involved in DNA repair and inflammation. Understanding the genetic basis of Barrett's esophagus could lead to more personalized risk assessments. We could use genetic testing to identify individuals who are at higher risk and recommend earlier surveillance or preventative measures. And it could pave the way for targeted therapies, drugs that specifically target the genes or pathways involved in the development of Barrett's. So genetics holds a lot of potential for how we approach the condition in the future. It's an exciting area of research, and I'm eager to see what breakthroughs emerge in the coming years. Now let's talk about inflammation. Chronic inflammation is a key player in the development of Barrett's esophagus. It's that constant irritation and damage to the esophageal lining triggered by acid reflux that sets the stage for those cellular changes we've been discussing. Here's how it works. Acid and bile reflux into the esophagus, causing damage to the lining. That damage triggers an inflammatory response, which involves the release of all sorts of signaling molecules and the recruitment of immune cells to the site of injury. And this chronic inflammation over time can lead to those cellular changes that characterize Barrett's esophagus, including intestinal metaplasia. So inflammation is like the bridge between GERD and Barrett's. It's the link that connects those two conditions. And if we can find ways to reduce inflammation in the esophagus, we might be able to slow down the progression of Barrett's and reduce the risk of complications. That's where diet and lifestyle modifications come in. While there's no magic diet that can cure Barrett's, certain changes can help manage GERD symptoms, reduce inflammation, and potentially slow down the progression of the condition. For example, losing weight if you're overweight or obese can make a big difference. Avoiding trigger foods like fatty or spicy foods, alcohol, and caffeine can also help reduce acid reflux. Eating smaller, more frequent meals can help too. And try to avoid eating late at night, as lying down soon after a meal can increase the risk of reflux. Elevating the head of your bed while you sleep can also help keep acid from flowing back up into the esophagus. And if you smoke, quitting is one of the best things you can do for your health, including your esophageal health. These lifestyle changes might seem small, but they can have a big impact on managing GERD and potentially slowing down the progression of Barrett's esophagus. They empower patients to take control of their health and potentially reduce their risk of complications down the road. And we've talked a lot about PPIs, those medications that reduce acid production in the stomach. They're incredibly effective for managing GERD symptoms, and they're often the first line of treatment for Barrett's esophagus. PPIs are generally safe and well tolerated, and they can significantly improve quality of life for people with GERD. They work by blocking the proton pumps in the stomach, those little molecular machines that are responsible for pumping acid into the stomach. By reducing acid production, PPIs can help protect the esophageal lining from further damage, and there's some evidence that they might even help slow down the progression of Barrett's esophagus. But PPIs aren't a cure, and there's still some debate about their long-term role in preventing cancer development. Some studies have suggested that they might reduce the risk of esophageal adenocarcinoma, while others haven't showed a clear benefit. More research is needed to clarify their role in Barrett's prevention. But for now, PPIs remain a valuable tool for managing GERD symptoms and potentially slowing down the progression of Barrett's esophagus. And while PPIs are the mainstay of GERD treatment, there are some newer medications on the horizon that might offer even more effective options. One class of medications gaining attention is potassium-competitive acid blockers, or PCABs. These drugs work differently than PPIs. They bind to a different part of the proton pump, preventing it from secreting acid. Early studies suggest that PCABs have several advantages over PPIs, including a faster onset of action and a longer duration of action. They also seem to have fewer drug interactions, which is important for patients who are taking multiple medications. Research is ongoing to evaluate the role of PCABs in managing Barrett's esophagus, but they hold a lot of promise as a potential new treatment option. We're also seeing research into targeted therapies, medications that specifically target the pathways involved in the development and progression of Barrett's esophagus. These therapies could offer a more precise and effective approach to treatment, potentially minimizing side effects and improving outcomes for patients. It's an exciting area of research, and I'm optimistic that we'll see significant advancements in the coming years.
Now let's talk about the importance of early detection and surveillance in improving outcomes for patients with Barrett's esophagus. We know that this is a precancerous condition and that it can progress to esophageal adenocarcinoma, but that progression is usually slow, taking years or even decades. That slow progression gives us a window of opportunity for early detection and intervention. If we can identify Barrett's esophagus early on, we can start monitoring it closely and implement strategies to potentially prevent or delay the development of cancer. And that's where surveillance comes in. Regular endoscopies with biopsies taken from any suspicious areas allow us to monitor the lining of the esophagus for any signs of dysplasia or cancer development. How often we do those surveillance endoscopies depends on the initial dysplasia grade. If there's no dysplasia, we might only need to do them every few years. But if there's high-grade dysplasia, we might need to do them much more frequently, even every few months. Early detection and surveillance are all about being proactive. They're about staying one step ahead of the game and giving our patients the best chance of a positive outcome.
And if we do find dysplasia, we have a powerful tool at our disposal. Endoscopic eradication therapy, or EET. ET encompasses a range of techniques that aim to remove or destroy the Barrett's tissue, effectively eliminating those precancerous cells that could potentially progress to cancer. We've already talked about some of these techniques like radiofrequency ablation and cryotherapy. They're minimally invasive procedures, but they can be incredibly effective. Studies have shown that ET can significantly reduce the risk of esophageal adenocarcinoma in patients with Barrett's esophagus. It's become the standard of care for patients with high-grade dysplasia, and it's increasingly being considered for patients with low-grade dysplasia as well. So EET is a valuable tool in our arsenal. It gives us a way to potentially prevent cancer development and improve long-term outcomes for our patients. But managing Barrett's esophagus is about more than just the physical aspects of the condition. It's also about addressing the emotional impact it can have on our patients. Receiving a diagnosis of Barrett's esophagus can be a lot to process. It can trigger fear, anxiety, and uncertainty.
And that's where we as surgeons need to step up and provide support and guidance. We need to communicate clearly and honestly with our patients, answering their questions and addressing their concerns. We need to validate their emotions and reassure them that they're not alone in this journey. We also need to connect them with resources like support groups or mental health professionals if they need additional help coping with their diagnosis. It's about treating the whole person, not just the condition. And that brings me to the importance of ongoing research and advancing our understanding and treatment of Barrett's esophagus. We've made incredible progress in recent years, but there's still so much we don't know. We need to better understand the molecular mechanisms that drive the development and progression of the disease. We need to identify more accurate predictors of which patients will progress to cancer and which ones will remain stable. And we need to develop more effective treatment strategies, including novel endoscopic techniques, targeted therapies, and even preventative measures. Ongoing research is crucial. It's the key to unlocking new knowledge, finding new treatments, and ultimately finding a cure for Barrett's esophagus. And clinical trials are essential for evaluating new treatment approaches and identifying the most effective strategies. Funding for research is vital to support these efforts and ensure that we continue to make progress in the fight against Barrett's esophagus and esophageal adenocarcinoma. All right, let's take a breath and recap some key takeaways from our deep dive into Barrett's esophagus. This condition is a precancerous change in the lining of the esophagus, and it increases the risk of developing esophageal adenocarcinoma. GERD is the main risk factor. So effective. GERD management is crucial, potentially slowing down the progression.
Diagnosis involves endoscopy with biopsies, and we have a range of treatment options: GERA control, endoscopic eradication therapy, and even surgery in some cases. And surveillance is absolutely essential for monitoring any signs of progression or recurrence. The exciting news is that we have new technologies and innovations on the horizon, and ongoing research is paving the way for better outcomes. Remember, early detection and timely intervention are key to improving outcomes for our patients with Barrett's esophagus.
Now, shifting gears a bit, let's talk about the role of proton pump inhibitors, or PPIs, in managing Barrett's esophagus. As surgeons, we know that PPIs are the cornerstone of GERD treatment, and for good reason. They're incredibly effective at reducing acid production in the stomach. But in the context of Barrett's, their role goes beyond just symptom relief. By effectively controlling that acid reflux, PPIs help reduce the inflammation in the esophageal lining. And theoretically, this could help lower the risk of further cellular changes and the development of cancer.
But here's where things get a little murky. The exact role of PPIs in actually preventing the progression of Barrett's esophagus to cancer is still being debated. Some studies have shown a potential link between long-term PPI use and a reduced risk of cancer, while others haven't been as clear-cut. More research is definitely needed to give us a definitive answer. But while the research continues, PPIs remain an important tool in our arsenal. They help us manage those GERD symptoms and potentially slow down the progression of Barrett's. Now, while PPIs are the current mainstay of treatment, there are some exciting new medications being investigated that could shake things up a bit. One class that's gaining a lot of attention is potassium-competitive acid blockers, or PCHEMs for short. These PCHEMs are interesting because they work differently than PPIs. They target a different part of that proton pump mechanism, blocking acid secretion at its source. And early studies have shown that PCs might have some advantages over PPIs. They seem to work faster, last longer, and potentially have fewer drug interactions. That last one is particularly important for our patients who are often on multiple medications. Research is ongoing to see how PCHEMs perform specifically in managing Barrett's esophagus, but they hold a lot of promise as a potential new treatment option. We could be looking at a shift in how we approach GERD and Barrett's management in the coming years. Another area of research that I find fascinating is the development of targeted therapies. These are medications designed to specifically target the molecular pathways involved in the development and progression of Barrett's esophagus. The idea here is to hit those specific targets with precision, potentially leading to more effective treatment with fewer side effects. It's a really exciting area of research, and I'm hopeful that we'll see some breakthroughs in the coming years that could significantly improve outcomes for our patients. Now, I want to emphasize this again. Early detection and surveillance are absolutely crucial when it comes to Barrett's esophagus. Remember, this condition has the potential to progress to cancer, but that progression is usually a slow process. This slow progression gives us a window of opportunity to catch it early and intervene. By identifying Barrett's early, we can initiate surveillance and put strategies in place to potentially prevent or at least delay the development of cancer. And surveillance, as we've talked about, typically involves those periodic endoscopies. It allows us to monitor the lining of the esophagus for any changes and to take biopsies if we see anything that looks suspicious. How often we do these surveillance endoscopies really depends on the individual patient and the grade of dysplasia we find. If there's no dysplasia, we might space those endoscopies out a bit further. But if we see high-grade dysplasia, we're going to want to monitor much more frequently, maybe even every few months. The goal of early detection and surveillance is to be proactive. It's about staying one step ahead and giving our patients the best possible chance of a positive outcome. And when we do find dysplasia, we have a powerful tool in our arsenal. Endoscopic eradication therapy, or ET. ET encompasses a variety of techniques, all aimed at removing or destroying that Barrett's tissue and eliminating those precancerous cells.
We've already discussed some of these techniques, like radiofrequency ablation, which uses heat to destroy the Barrett's lining, and cryotherapy, which uses freezing temperatures to achieve the same goal. These ET techniques are minimally invasive, but they can be remarkably effective. Studies have shown that ET can substantially reduce the risk of esophageal adenocarcinoma in patients with Barrett's esophagus. It's become the standard of care for patients with high-grade dysplasia, and it's increasingly being considered for those with low-grade dysplasia as well. ETT gives us a real chance to potentially prevent cancer development and improve long-term outcomes for our patients. But managing Barrett's esophagus is not just about the physical aspects of the condition. We have to remember that there's a human being on the other side of this diagnosis, and a diagnosis like Barrett's esophagus can be a heavy load to carry. It can trigger a whole range of emotions: fear, anxiety, uncertainty. And as surgeons, it's our responsibility to be sensitive to those emotions and to provide the support and guidance our patients need to navigate this challenging diagnosis.
Open and honest communication is essential. We need to make sure our patients understand their diagnosis, their treatment options, and the potential risks and benefits of each approach. We also need to be good listeners. We need to hear their concerns, validate their emotions, and reassure them that they're not alone in this. Sometimes connecting them with resources like support groups or mental health professionals can be incredibly helpful. Remember, it's about treating the whole person, not just the condition. And this brings me to another crucial point: the importance of ongoing research. We've come a long way in understanding Barrett's esophagus, but there's still many unanswered questions. We need to keep digging deeper, exploring new avenues, and pushing the boundaries of knowledge. We need to better understand the molecular mechanisms that drive the development and progression of this disease. We need to find more accurate ways to predict which patients will progress to cancer and which ones won't. And ultimately, we need to find more effective treatment strategies, including novel endoscopic techniques, targeted therapies, and even preventative measures. Research is the key to unlocking new knowledge, finding new treatments, and ultimately finding a cure for Barrett's esophagus. Clinical trials are essential for evaluating new treatment approaches and figuring out what works best. And funding for research is vital to support all these efforts and ensure that we continue to make progress in the fight against Barrett's esophagus and esophageal adenocarcinoma. Now let's take a moment to talk about the role of genetics in Barrett's esophagus. We know that chronic acid reflux, that GERD, is the primary trigger, but genetics also plays a significant role influencing an individual's susceptibility to developing this condition. Researchers have identified certain genes that seem to increase the risk of Barrett's esophagus, but the exact mechanisms are still being unraveled. Some of these genes are involved in processes like cell growth and proliferation, while others play a role in DNA repair and inflammation. And as we gain a better understanding of the genetic underpinnings of Barrett's esophagus, it opens up some really exciting possibilities. Imagine being able to use genetic testing to identify those individuals who are at higher risk of developing Barrett's. This would allow us to recommend earlier surveillance, maybe even implement some preventive measures, and it could even lead to the development of targeted therapies, drugs specifically designed to target those genes or pathways involved in the development of Barrett's. It's a fascinating area of research, and I'm really excited to see what the future holds. Now let's delve into the intricate world of inflammation. Chronic inflammation is a key player in the pathogenesis of Barrett's esophagus. It's that constant irritation and damage to the lining of the esophagus triggered by acid reflux that sets the stage for all those cellular changes we've been talking about. Let's break it down step by step. When acid and bile reflux into the esophagus, it causes damage to the lining. This damage triggers an inflammatory response,
which involves the release of inflammatory mediators, these signaling molecules that call in the troops. These mediators attract immune cells to the site of injury, and that further amplifies the inflammatory response. And over time, this chronic inflammation can lead to significant cellular changes in the esophageal lining. It's like a constant battle going on, and eventually it can lead to the development of intestinal metaplasia, the hallmark of Barrett's esophagus. So you can see how inflammation is a crucial link between GRD and the development of Barrett's. It's like the bridge that connects those two conditions. And that's why finding ways to reduce inflammation in the esophagus is so important. If we can calm things down, we might be able to slow down the progression of Barrett's and reduce the risk of complications. And that's where those lifestyle modifications we talked about earlier come into play. While they might seem small, they can make a big difference in managing GRD and potentially slowing down the progression of Barrett's esophagus.
Remember, it's about empowering our patients to take an active role in their health. Things like maintaining a healthy weight, avoiding trigger foods, eating smaller meals, and quitting smoking can all contribute to reducing inflammation and improving their overall well-being. These lifestyle changes, combined with appropriate medical management, can make a real difference in the lives of our patients with Barrett's esophagus. So we've covered a lot of ground in our deep dive into Barrett's esophagus. Let's wrap things up with a few key takeaways, especially for those of us in surgical practice. First up, screening. While there's no universal agreement on screening every single patient for Barrett's, we have to be extra vigilant about those who are at high risk. Think about those patients with chronic giardia, especially if they tick several boxes on that risk factor list. Things like male gender, being of white race, over 50, central obesity, a history of smoking, and of course a family history of Barrett's or esophageal adenocarcinoma. Those are the patients we want to consider for endoscopic screening.
Next, let's talk diagnosis. If, based on symptoms and those risk factors we suspect Barrett's fits, then esophageal gastro-duodenoscopy with biopsies is our gold standard for confirmation. And remember, it's not just one finding that seals the deal. It's that combination of seeing the salmon pink mucosa extending at least a centimeter above the gastro-esophageal junction, and then having the pathologist confirm intestinal metaplasia on those biopsies, especially the presence of goblet cells. That's when we can say with confidence, yes, this is Barrett's esophagus. And finally, let's touch on management. Once we've diagnosed Barrett's, our approach has to be tailored to the individual patient. If there's no dysplasia, our focus is on long-term management of that GRD. Proton pump inhibitors are key here, helping control the acid reflux and potentially reducing the risk of progression. Of course, we also need to schedule those regular surveillance endoscopies to monitor for any changes. Now, if we do find dysplasia, our approach needs to be more intensive. For high-grade dysplasia and sometimes even low-grade endoscopic eradication therapy is often the go-to.
Techniques like radiofrequency ablation cryotherapy or endoscopic mucosal resection are all aimed at eliminating that precancerous tissue and reducing the risk of it turning into esophageal adenocarcinoma. And in those more advanced cases, or when endoscopic therapy isn't feasible, surgery might be necessary, such as an esophagectomy. Managing Barrett's esophagus effectively really requires a team effort. It's about gastroenterologists, pathologists, surgeons, and oncologists all working together to provide the best possible care for our patients. And we can't forget about the importance of staying up to date. Barrett's esophagus is a dynamic condition, and how we understand and manage it is constantly evolving. New research guidelines and technology are emerging all the time, and it's our responsibility to stay informed so we can provide the most effective personalized care to our patients. Thank you for joining me on this deep dive into Barrett's esophagus. I hope you found it informative and helpful for your practice. Until next time, keep those surgical minds sharp.